Hello, I'm Michael Hainsworth. Artificial intelligence has gotten a bad rap ever since ChatGPT started making headlines for helping students write their essays. But machine learning algorithms and the AI that comes from them have been used for several years in the healthcare sector. IBM's Watson may have beaten Jeopardy whiz kid Ken Jennings in 2011, but its real power was in combing through thousands of cancer research reports that get published every year. Meet Helen Angus. She's the Chief Executive Officer of AMS Healthcare and a participant in the November 12th Roundtable Luncheon titled Prescribing Innovation, AI as a Catalyst for Change.
You can predict somebody who's going to deteriorate, and then you can intervene early. So there's a clear patient benefit, and it offers an opportunity either to change the trajectory of a disease, a person with a disease, because you've been able to do something earlier on that actually changes that, or in some cases you can bring family members in if it isn't fixable and someone is in the last stages of life.
And this is Rosalie Wyonch. She is a senior policy analyst at the C.D. Howe Institute with a special focus on the evolution of healthcare services in Canada. They join us now. Thank you for joining us.
Always happy to chat.
Good to be here.
Helen, Canada does have a reputation for AI research, but where are we when it comes to the applied AI for healthcare?
I don't think AI is actually much different than other innovations in healthcare where we've got pockets of excellence. We have a little trouble scaling up on a sort of pan-system or pan-Canadian basis to harness the full benefits of AI, and I think that's the story of the last 30 or 40 years of healthcare and innovation generally.
There certainly are pockets of excellence, and though we probably have the same challenges with scaling as we do in other areas of healthcare innovation, I just maybe wanted to highlight one or two things that I thought were a bit exciting or a little bit new. And one of those is that part of the siloing in healthcare is really locks up data. And as a researcher, I'm always wanting to get access to data, but at the same time, we need to protect the confidentiality of patient data and also just ensure that that's all handled the way that it should be. And that's one area where I think AI is making strides, is in developing synthetic data sets for researchers. That's something that's actively being developed in a couple pockets across the country, as well as the work that's being done by the Vector Institute and Amy. So there, just to say that those little pockets of excellence do have some pretty cool and exciting things happening in them. But at the same time, I'd share Helen's sentiment that isn't necessarily going to be a system-wide thing quickly. But at the same time, I want to be as optimistic as possible about the cool things we are doing.
Yeah, I do think, though, that there are things that we can do as a system to make sure that those pockets actually expand into other locations. And maybe we can talk a little bit about that later.
How about we talk about it right now?
Yeah, so I think there are things, obviously a big push on the data side, because that's really the engine of AI and the applications. I think that there are things in the administrative, so lots of complexity in the clinical uses of AI. But if you think about some of the back office uses, digital scribes and other things, I mean, it's I guess I'm impatient. I think it's time to kind of get on with it. The early results from, some of the, early implementation looks very, very promising. We just need to sort out who's going to pay for it and how it's going to actually be spread into more clinical settings. Anyway, I just think that there are things like training and how do we build teams and how do we incent the right behavior. Rosalie already just mentioned the word silo. I think that there are opportunities to use, all the levers that we have for change to make sure that AI is adopted and adopted responsibly. And that would include, innovative funding models, incentives, perhaps, training for health professionals and others to be able to use AI. So it's a whole list of things that we need to do this well.
See, that's a very interesting point. I opened by talking about the clinical side of things like Watson combing through all these documents because doctors simply don't have the time of day to go through 1,000 of them a year or what have you. But while AI for diagnostics gets all the attention, let's talk a little bit about the role that machine learning and AI will play in the administrative side of healthcare, because that doesn't get a lot of attention. But here at the Institute, where we're very focused on how much things cost, I can imagine AI for administrative work in the healthcare system would help reduce those costs.
Yeah, I think it would. There's certainly, you're well aware that we've got some challenges in primary care, for example, and there has been an evaluation of the implementation of digital scribes in about 150 different family health practices. And, again, the results look incredibly promising. So it reduces, pajama time, releases time for care, and looks like it's actually fairly easy to implement in a clinical context. All that is doing is basically taking the notes kind of in real time and then transcribing those into the health record. So it's not taking the place of clinical judgment at all, but it is allowing primary care to work more efficiently and spend time directly with patients, which is what people need. So that's probably one of the most promising examples. And it probably has fewer ethical and regulatory concerns than you have in a fully clinical application of AI.
Yeah, and maybe I would add there that when we are in a space where we have a lot of people that don't have access to primary care, there's lots of talk about hospitals, long-term care, essentially all of our institutional healthcare also having difficulty with maintaining full staff, and just how much we are spending in that area, both on full-time staff and on agencies to fill the gaps, that we should really think about not just having more nurses or hiring more people, but how they can use their time better. And so anything where AI can essentially improve the flow of information or reduce the time that health providers need to spend on, I'd say, admin work or just looking up previous results or tracking down information, anything where AI can actually really improve those information systems and reduce their administrative load is highly beneficial to the system, because that frees up their time and can actually help us start working through some of these access challenges, but without creating the space somehow. We're kind of always trying to catch up. And so we need to create that space somehow. And I think that AI can be a tool to help enable that.
We've spent the last 3 years or so, at least at the enterprise level, talking about skunkworks projects in AI, getting large organizations on board with artificial intelligence by not doing a moonshot project, starting off small, trying to figure out what works, what doesn't work, dealing with the change management that comes with introducing artificial intelligence as well. And return on investment is sort of a secondary consideration, if it's even being considered at the enterprise level at all for many organizations. Do we have a dollar value sense, a percentage value sense? Can we quantify how much we save by adopting AI at the healthcare level?
Yeah, some of the consulting firms have tried to quantify it. I don't know what the assumptions are behind the numbers. They're fairly substantial if AI was used in, I think, all its different contexts. So streamlining administrative purposes, improving population health, so doing a better job at providing preventative care and to people. Looking at, again, the clinical uses, trying to predict whether people are going to deteriorate, the diagnostic purposes, and then you think about the consumer uses of AI as well. So, it could be a pretty big number, but to get to that number, I'll go back to where I was, a few minutes ago. It really requires, again, implementation at scale using, implementation science kinds of tools and levers in a pretty structured way. So, I think we're a fair way away from harvesting all the potential benefits. And there's some risks that we obviously have to address as well at the same time.
Before we get into the risks, Rosalie, since the provinces are the domain of healthcare delivery, what role does government have to play in adoption?
Well, I think that the government has lots of potential roles it could play. And I think really, if we want to get to sort of that systemic wide adoption, it has to be at least partly a government involved policy. And maybe partly, I'll go back a bit to just sort of our general innovation conversation, where we have successful pilots or, sort of those centers of excellence where we're getting these good results. But when we have the proof of concept, we have the evidence that it works, and we have some idea of what the costs would be, at least in our specific context. But then that kind of leads to the question, why does it then stop there? And so one thing that I would really point out is that in our current sort of way of thinking about innovation, particularly in the hospital system, there's all of these competing priorities at all times, but also once we do a pilot, that might be funded and have a sort of timeline, check-ins, and then there's a report, but there is very, very rarely a connected pathway from a pilot. We don't necessarily assume the pilot will be successful and start developing the plan for broader implementation. It's sort of we generate evidence, we assess, and then you almost have to go back to square one with the idea of scale being a different thing. Or at least that's my understanding. Helen, obviously, please jump in with your experience because you've definitely been on the inside. But that's my impression of sort of, from a government financing perspective, kind of why we might run into these challenges. As well, if you're short on staff and you don't actually have budget dedicated for change management, it can become, I would say there's a lot of different points along the pathway to scaling and adoption where something can stall. And so since we do have excellent things going on, we do have a strength in research, we have the skilled professionals, I think there really is a role for government and health system administrators to think differently about innovation and actually build those pathways. I guess I would say, what would change if we assumed the pilot was going to be successful and came up with what is step 2 on the scale and implementation?
Yeah, I'm not going to disagree with you. I think you're exactly right. I'm hopeful though. And I'll go back to an experience I had when I was working at Cancer Care Ontario, where we were able to take, innovation, standards of care, and implement them province-wide using, again, all the levers. So clinical leadership, performance measurement, performance monitoring, and sort of implementation rigor. And it wasn't just, in a single site, it was across all the cancer centers, and this goes back to the early 2000s. So there are examples of where we've done this before. We just need to apply all those levers. I'm a big fan of the NHS change model because I think it sort of points out all the things that you need to have put into place in order to affect implementation system-wide. And in that regard, I don't think AI is that different. It has some unique characteristics of risk and that probably need some attention. But to get to scale, I think we actually have a recipe. We have a track record. We just haven't applied it perhaps as often as it is needed. And I think AI would be a great candidate for basically, putting a very sharp implementation focus and, assigning accountability, and whether that's government in Ontario, or whether it's Ontario Health, or whether in other provinces of similar organizations, to actually make sure that when AI becomes a standard of care for patients, that in fact that all patients benefit from it, and it's not just the domain of the pockets where the AI is being generated.
Helen, is there a particular province that is implementing AI right that we should be looking to?
Yeah, I don't know that there's any, particular province that is leading. I think obviously Ontario has a critical mass of AI researchers that are really doing the proof of concept. I happen to be on the board at Unity Health. As of last year, there were 53 unique installations of AI, within the hospital system. And so you see that, again, there's a lot going on, but the scale up, there's some things that are starting to get some traction, but the scale up, again, to the fullest understanding of the province, I think, is still elusive.
You touched on something a little bit earlier, and I want to come back to that, which is, I suppose, more in the change management component to this with medical professionals. I like to think back to about 14 years ago when I broke my foot. And I thought I had just cracked a knuckle kind of thing while I was doing some construction work. 2 weeks later, the foot's still blown up. And I go on the internet, and the internet's like, you should probably go see a doctor about that. So I did. And when I told that story to the doctor very derisively said, oh yeah, Dr. Google, huh? And he sent me upstairs for an x-ray. I come back downstairs with the CD-ROM of my x-ray, which tells you what kind of technical environment I was dealing with even then. And he didn't even look at it. He says, oh, well, you clearly have broken your foot, otherwise they wouldn't have given you the disc. I said, oh, Dr. Google, huh? Do medical professionals fear AI will take their jobs like the general workforce kind of does, or like that doctor 14 years ago figured that a search engine would do?
Maybe I'll jump in on that one and say that first I'd like to say that when we're in shortage, like when we don't have enough healthcare providers to begin with, nobody should worry about losing their jobs, because, it would be people that don't exist that we wouldn't hire in the future. It wouldn't be anyone today is losing their job, because we need more access, we need more providers. And even if we didn't, I'm sure that we could find ways to expand the healthcare system to just, provide that much more care. I wouldn't want to think of it as like, even though these technologies could potentially be labor saving, that doesn't mean that they're labor replacing. Particularly in healthcare, where, for lots of both human and regulatory reasons, you do need the doctor to make the clinical assessment. You do need sort of that additional validation. And the one other thing I would point out is actually previous advances in technology, in a lot of cases, become very beneficial for the physicians because they become more efficient. They can do more procedures faster with fewer complications for their patients, and especially in a fee-for-service model, that means they make a lot more money. In some cases, some of these technologies can actually increase costs for government, but that's just because we actually provide that many more services. So it's sort of this, it's to try not to get too into economics jargon, this really is a productivity question. And then where do the gains from that technology accrue? Is it savings? I guess really cost avoidance on the government side, or is it additional revenue for the physicians and the hospitals? And depending on how the system is set up or what technology you're discussing, there's a pretty good historical case that the doctors do extremely well when new technologies hit the market, and that the government might not actually realize quite as many savings as it would hope. But neither of those necessarily are a bad thing, because if we're doing that many more procedures and patients then have better access to care, then that's arguably a good thing, even though it might be more expensive. And it really depends on the technology, how effective it is, and then sort of where the freed up cost abatement goes. And does it benefit the government or does it benefit the providers? And generally the answer is a bit of both. So there's a lot of reason that they should actually want these technologies. And for those that would be concerned about losing their jobs, I can say both the speed of adoption of these things and the current need for new staff means that nobody that's currently working should worry about losing their jobs.
Yeah, I would agree entirely. I think there may be some changes to people's jobs. I was listening to a physician leader from Mass General last week, and he was talking about the introduction of AI into the clinical environment expands the team. So it means that when you have AI deployed, let's say in a hospital, you need to be looking at both the intended and unintended impacts of the use of AI. You need to look at the fidelity of the results using AI over time. Is there any degradation of the outcomes of using AI? You probably need to have ethicists and data scientists. So it may change the team. And so, that is a change management challenge. I'm with Rosalie. I don't think anybody is losing their job, but it does have the potential to change how people work. And health, has the benefit, I guess, in some ways of not necessarily being the leader in AI as a sector overall. We like to think we've got, some terrific use cases, and we do. But there are other industries that are making more widespread uses of AI, and we can see, some of the things that in the disruptions that AI is having in those sectors, and even just think about the creative industries and artists who are concerned about what it means, and in the transportation sector and other places. So I do think the change aspect is something we have to pay attention to, but I'm not worried about job loss.
Yeah, move fast and break things is a phrase that the tech industry likes to use a lot. But I can imagine when it comes to important things like finance or healthcare, the last thing you want is an organization moving fast and be willing to break things. Helen, AI does get a lot of negative press, though, when consumer-facing industries adopt the technology poorly or when it's overhyped. You mentioned privacy, and I suppose we should extend that into bias concerns for artificial intelligence as well. We're in the third wave of AI. We got it in the 50s, and then we realized we didn't have enough computing power to make it real. We got it in the 80s when we got the computing power, but we didn't have the data for it. And now we've got the big data and the tech to bring it all together. I thought we already resolved the bias and the privacy concerns over just the last 5 years as issue number 1 and 2 back then.
Yeah, I think, at the end of the day, the implementation of AI, and people have said this, and I'm not being original here, moves, some of this moves at the speed of trust. And so being able to explain to people how their data is going to be used, to be able to monitor outcomes, positive and adverse outcomes, will be important, that there's somebody minding the store, and that there's accountability, that the biases, I think, are a real concern. And I think that those are things that can be addressed through transparency, through ongoing monitoring, to engagement with citizenry, patients, and their families. So I think it requires a fair bit of, engagement in order to continue to, build the trust because of people's natural skepticism about AI, and the fact that it's kind of hard to explain, and the fact that the capabilities, as you mentioned, it's almost exponential in terms of, the things that AI is going to be able to do, 2 years from now versus today. And so trying to kind of explain that in layperson's language, I think, is something that we need to pay attention to.
On the trust aspect, I think that, sort of the tech adage of move fast and break things is part of why people are a bit skeptical. But I would say that the healthcare space is such a highly regulated space already that if something is going to be brought into a clinical setting and gets the sign off of people within the healthcare system, then though there is still, some kinks to work out, you can be pretty sure that it is really up to those standards of safety, and that we are certainly going to be thinking about the ethics, the potential for bias, and all of those other aspects. And I would say because of the level of potential risk in both, you mentioned finance and healthcare, I think those are actually the areas that are most likely to actually get some additional regulations, but being that they're already so highly regulated, and the potential of the consequences of the risk could be so bad, that it's really something that no one is not taking seriously. Healthcare doesn't really have the move fast, break things. It specifically is about careful, do no harm as a culture. And so I think if there's one area where people shouldn't be as concerned about that sort of move fast, break things in tech, it would be the healthcare space, because everyone involved in that system has at some point over many issues had to think about the ethics of taking different actions and having to think about those things. And it is already a highly regulated space where the technologies are evaluated through standard processes. And so I think this particularly is an area where there are applications where we have either addressed what could potentially be the bias issue, or where it's simply about sort of administrative processes or back end where it's less of an issue because it's not making, shall we say, clinical decisions where those concerns would be higher. It can just simply sort of be back end and doing some of the grunt work that frees up healthcare worker time to then be able to provide more patient care. And so I guess I've got a couple of points in there, but mostly it's just that though there are likely to be more regulations, this is already such a regulated space that people shouldn't be too concerned about these new tools, because these questions are already part of the process.
Do you have a favorite use case?
I like the ones where I've seen a little bit more up close, where you can predict somebody who's going to deteriorate, and then you can intervene early. So there's a clear patient benefit, and it offers an opportunity either to change the trajectory of a person with a disease, because you've been able to do something earlier on that actually changes that, or in some cases you can bring family members in if it isn't fixable and someone is in the last stages of life. I think those things that actually benefit patients and support the team, those are probably the ones where, again, it's understandable, and where I think you've got some, enough of a use case, and we know the acceptability, and I think those are pretty attractive.
If there was one thing you wanted the listener to take away from our conversation today, what would it be?
I think that there's a lot of great potential for various AI tools to improve care, particularly the productivity of care and also access. Like Helen, I would really point to the ability to intervene earlier to prevent sickness as opposed to treating illness would be, I think that's a world we can all look forward to. But also just really, if there's one takeaway, it's that this stuff has the power to really improve our lives, but at the same time, it's not likely to happen so quickly that it's going to be disruptive. It's much more likely to just be a process of improvement, like any other wave of technology we've seen in the past. But at the same time, it's an ongoing space, and none of us predict the future. So we'll see what happens, but I'm optimistic.
Yeah, I would agree. I'm optimistic. I think we have to pay attention through the implementation to the human aspects of this, whether it's how care teams are organized and do their work, whether it's the impact on patients and their families, and what the experience of getting care supplemented by AI. I think those are things that need to be studied and need to sort of ongoing consideration and ongoing diligence as we implement AI at scale.
Thank you so much for your time and insight today. This has been great.
More than welcome. It's a pleasure.
Always happy to chat.
Helen Angus is the Chief Executive Officer of AMS Healthcare and a participant in the November 12th Roundtable luncheon titled Prescribing Innovation, AI as a Catalyst for Change. Rosalie Wyonch is a Senior Policy Analyst at the C.D. Howe Institute. For further insight into the challenges facing Canada's healthcare system, visit cdhowe.org and sign up for the podcast on YouTube or wherever you get your favorite programs. I'm Michael Hainsworth. Thanks for joining us.
You've been listening to the C.D. Howe Institute podcast with Michael Hainsworth. Subscribe on iTunes, Google Play, and Spotify. The C.D. Howe Institute is an independent, not-for-profit research institute whose mission is to raise living standards by fostering economically sound public policies. The Institute is widely considered to be Canada's most influential think tank and a trusted source of essential policy intelligence, distinguished by nonpartisan, evidence-based research and subject to definitive expert review. Visit cdhow.org and follow us on Twitter and LinkedIn. Thank you.